HFpEF diabetes. Semaglutide in patients with obesity-related heart failure with preserved ejection fraction and type 2 diabetes. Type 2 diabetes is highly prevalent in patients with HFpEF and is characterized by a more severe phenotype with greater symptom burden and worse functional class. In STEP-HFpEF, semaglutide significantly reduced heart failure-related symptoms and physical limitations, as well as body weight, in patients with obesity-related HFpEF who did not have diabetes. STEP-HFpEF diabetes is the first to investigate the effects of semaglutide in patients with obesity-related HFpEF and diabetes. There are many potential mechanisms to postulate the benefits of semaglutide in the obese phenotype of HFpEF. They include both weight loss-related mechanisms on the right of the screen and weight loss-independent mechanisms on the left. So 616 adults who had documented HFpEF and diabetes were randomly assigned to either semaglutide with a target dose of 2.4 milligrams sub-Q weekly or matching placebo and treated for 52 weeks. The key inclusion criteria include a left ventricular ejection fraction greater than or equal to 45% with a functional class 2 to 4, a KCCQ score less than 90 points, and a 6-minute walk test greater than 100 meters, and one of the following criteria listed below. Key exclusion criteria included prior or planned bariatric surgery, recent weight change, recent adverse cardiovascular event or heart failure hospitalization, hypertension, history of type 1 diabetes, or recent use of GLP-1 receptor agonist or uncontrolled diabetic retinopathy. Here are the baseline characteristics. Majority of patients were white women. Mean age was 69 years. Average body weight was 103 kilograms or 227 pounds. Median BMI was 37 and 2/3 of the patient had a BMI greater than 35. The average ejection fraction was 56% and most patients had NYJ class 2. The median KCCQ score was 59 points, which indicated quite profound and symptomatic and functional impairment. And as you can see, the median 6-minute walk distance was only 280 meters, which is quite low. Most patients received background therapies of beta blocker, RAS inhibitors, and diuretics. About 1/3 were receiving MRAs and SGLT2 inhibitors. Here's part 1 of the dual primary endpoint. The semaglutide group had a significantly greater improvement in the KCCQ score compared to placebo. The improvement was noticeable around 20 weeks and progressively amplified throughout the course of the trial. At 52 weeks, the estimated treatment difference between the two groups was 7.3 points in favor of semaglutide with a p-value less than 0.001. The second dual primary endpoint was a change in body weight. Again, there was an early benefit with semaglutide. At 52 weeks, the treatment difference was 6.4%. Patients treated with semaglutide had a significantly greater improvement in 6-minute walk distance. At 52 weeks, the treatment difference was 14.3 meters greater in the semaglutide group with a p-value of 0.008. Semaglutide produced more win ratios of clinical benefit versus placebo, 58.7% versus 36.8%, giving a win ratio of 1.58. Of note, there are more wins with every component of this hierarchical composite with semaglutide. The safety profile was quite favorable. About 18% of patients in the semaglutide group had a serious adverse event versus 29% of patients in the placebo group, which is highly significant. There are actually fewer serious adverse events in the patients treated with semaglutide. This was predominantly accounted for by fewer cardiac disorders. There was no difference in all-cause death. There was no difference in discontinuations due to serious adverse events, but not surprisingly, more people stopped semaglutide due to GI adverse events. There was no significant difference in hypoglycemia or retinal disorders. When looking at STEP-HFpEF in patients without diabetes and STEP-HFpEF in patients with diabetes, both are obesity-related heart failure trials. The only difference is in the magnitude of weight loss between the two trials. There is 40% less weight loss in the diabetes trial. However, for every other endpoint, including KCCQ, 6-minute walk, markers of inflammation, congestion, heart failure events, there's virtually no difference. So in conclusion, in patients with obesity-related HFpEF and type 2 diabetes, semaglutide 2.4 milligrams produced larger reductions in heart failure-related symptoms and physical limitations, greater weight loss, and greater improvements in exercise function compared to placebo. Semaglutide also resulted in lower NT-proBNP, suggesting important disease-modifying effects. Semaglutide was well tolerated. Semaglutide reduced hemoglobin A1C without an increase in clinically significant hypoglycemia or diabetic retinopathy events. Collectively, these results, along with HFpEF, indicate that the treatment with semaglutide is a valuable therapeutic approach in the management of patients with obesity-related HFpEF, both with and without type 2 diabetes.